inviting Dr. Akhil to give us a talk about identifying and treating EGFR 20 insertions.
Thank you. Can you stop sharing so that I can share the slides?
Akhil, over to you.
Yeah, thank you. So after very heated and detailed discussions where the sequencing is definitely remains an issue, we come back to a somewhat easier area where we see very limited
Sorry, one second, Akhil. 1 second. If Kumar sir is still there, then he can also share his opinion at the end of the presentation. So Kumar sir had joined late. He missed the scalpelling session. So we'll just have
We'll do that. We'll do that. In the end,
Great. Thank
you.
Please
go ahead. Please go ahead. It is very nice. I learned quite a bit in the breast session.
Great. Thank you. So it seems that now we are moving towards multiple precision therapy options, not only in lung cancer, but in breast cancer as well. Now I will come back to my hardcore area of lung cancer, which we have learned from Kumar sir in the EGFR exon 20 space. So what is the most important point when we see EGFR exon 20? We usually used to say a very small number of patients previously, but now we are seeing in quite a huge number of patients. Why? This is because of the shift in the practice from RT-PCR to NGS-based testing. And if we have to tell one line, especially for our residents who are asked why EGFR exon 20 incidence has increased, most important point is that we need to highlight the EGFR RT-PCR probe, COBAS version 2, which we utilize, that has only 42 types of probes or types of mutation which it is able to detect, while we know there are already 80 types of exon 20 insertion mutation. So how we can expect a probe RT-PCR based testing to detect all exon 18, 19, 20, 21? This is completely not feasible. That is why there is a need of NGS, and I think there's no further discussion required. We all are doing NGS now, thanks to various initiatives taken under the leadership of Kumar sir. One of them is Lung Alliance, which is definitely helped our patients. And even TMH Varanasi utilized more than 300 patients free NGS testing when Lung Alliance project was started. So this is what we know. EGFR exon 20 space, always they have limited treatment options. We had initially osimertinib compassionate access when we were doing DM. We also tried mobocertinib. Mobocertinib was seeming to working well, but it failed to reach the data required for the cutoff. Further development is stopped. Osimertinib, we know it doesn't work well in exon 20 insertion, except some specific YVWMA mutations. Amivantamab, it is a different drug altogether. It is not a TKI. It is a monoclonal antibody. And that is why it seems that there is good data for the same. And we know the outcomes are really bad for exon 20 insertion mutations. If we see the PFS data, yes, with EGFR TKI, the PFS is just 1.4 to 3 months and response rates are below 20%. So again, we know that this is an area which needs significant attention, and we are working towards it constantly. Unmet need, molecular testing under diagnosis, which we have already covered. PCR will miss 50% of EGFR exon 20 insertion to be precise. And that is why we need NGS in all patients. And thankfully, we are able to do it now, even in resource constraint setting. The good part is that EGFR is able to inhibit both EGFR and MET. It's a bispecific antibody. And that is why it is able to work even in patients who have MET mutations or MET amplifications post progression on osimertinib also. That is an utilization also available. And what is, since it is a monoclonal antibody, it is binding at the extracellular binding of the cell surface. That is why its mechanism is completely different from a TKI, and it acts in a different way. So this is what it binds at the surface. There is lysosomal activation, tumor cell lysis, and through trogocytosis, antibody-dependent cellular toxicity, there is a activation of immune cell response and killing of the cancer cell. And there is also a very important mechanism, which is not a clinical way, but what we has been seen in the studies. The low fucose region of amivantamab promotes trogocytosis. That means movement of the cell and activation of NK cells and macrophages, leading to more cell lysis of cancer cell. So that is what is the mechanism. This is what we tried to cover: amivantamab, the inhibition of ligand binding, receptor degradation, and immune activation. So there are two data sets for amivantamab: first line Papillon study, which we are aware, Exon 20 insertion, and the second line Chrysalis data with which is their post progression on platinum. And thankfully, India was a participating center. TMH Mumbai under Kumar sir, there was a participating site, and this has been covered in multiple publications as well. So if we see the EGFR Exon 20 insertion, chemotherapy plus amivantamab, Papillon phase 3 trial, and post chemotherapy progression, amivantamab, Chrysalis phase 1, phase 2 trial data is also there. So this is the Exon 20 insertion trial of Papillon, which showed amivantamab versus chemotherapy, and it showed a significant improvement in the outcomes. This is a large trial of 300 plus patient doing only in Exon 20 insertion mutation space. So that needs to be done at centers where there is proper NGS facility and NGS utilization. So what we see, patients had at 1 year progression-free survival improved from 13% to close to 50% and hazard ratio 0.39. Very few drugs in oncology have hazard ratio below 0.7 or 0.75. And here the hazard ratio is below 0.4 actually. So that is why we know that this is one of the very useful drugs in oncology, unlike many of Me Too drugs, which have hazard ratio of 0.7, 0.8, 0.85. So yes, 60% risk reduction, doubling of the PFS, and 10 times difference in the PFS rate at 18 months. And you can, with such effective drug, we expect all the points in the forest plot to be at one side. This is what is we are able to see as well. So that is confirms benefit across all the subgroups. And this is what a good waterfall plot looks like. You see hardly any patient progressing, all the patients having this significant responses, and the responses most of the time are very deep. You can see these blue lines, these achieving partial response and beyond, and some patients having CR as well. So this is what is the data set. Overall response rate reaching 65 to 70%, and overall response rate is 1.5 times. Again, duration of responses are sustained in a majority of the patient, doubling of the duration of response. And if we see this PFS2 data also, since this drug is acting not only directly chemotoxic way, it is also acting in some trogocytosis method, antibody dependent cellular toxicity, cytotoxicity. It is expected to have improved PFS2. So all effective drugs who are prolonging OS, they are known to have good prolongation of PFS2 as well. So this is what we see, a significant improvement in the PFS2, supporting again first line use of amivantamab.